Good afternoon, and welcome to Why True Integration Requires a Primary Focus on Behavioral Health. I'm Julie Miller, Editor-in-Chief for the Institute for the Advancement of Behavioral Healthcare. Today's program is sponsored by Echo Group. Thank you to our sponsor and to everyone in our audience for giving us your time and attention today. Before we get started, we do have a few housekeeping details. Please use the Q&A area below the slides to submit a question at any time. You don't have to wait until the end of the program to submit your question. To download the slide deck, please click on the Resources tab to the right of the presentation window. If you need tech support, please click the Test Your Connection button below the video window to chat with support. Finally, you can also join our webinar conversation on Twitter by using the hashtag IABHCLiveWebinar. At this time, it's my pleasure to introduce our speaker for today. Suki Norris is a senior knowledge engineer and joined the Echo Group in 1996. She has more than 35 years of experience in healthcare, including healthcare law, managed care, and behavioral health. To read more about her, please click on the link below the Q&A area. Suki, thank you so much for taking the time to speak with us today. I'll turn the audience over to you.
Thanks very much, Julie. And I just want to say before I get started, as the folks that I'm working with know, 35 years ago I was in kindergarten, and that's when I started in this industry. So don't do any calculations about how old I might be. Today's talk is really based on some thoughts I've had recently about the changes that have happened in healthcare and the provision of healthcare services. There was a time way back when, it was before my time, mind you, where services were provided by your neighborhood PCP, and he knew the family. He would even make house calls sometime. He delivered your children and your children's children, or she had delivered your children and children's children, and they were the people that you talked to. They handled it when you lost your job and you were depressed. They handled it when your kid had trouble in school. They were your coordinated care. It was a person or a couple of people who knew you, knew who you were, knew your name, but more importantly, they knew you. Well, times have changed, and that's not the way it works anymore. We've gotten more sophisticated, some could say, in our provision of healthcare services, maybe more formal in our provision of healthcare services, or fill in the blank. And what we're looking at now is integrated healthcare services. And that's what we're going to talk about today. To look a little bit at the agenda, we're going to get a definition, a working definition of integrated care, and kind of look at what works and doesn't work within integrated care. And then, and I'll create the understanding of why this is the next topic, we're going to look at person-centered care. How is that defined in today's provision of healthcare services? And then the reason that I put together this presentation, I want to talk about an idea of a solution that I have after doing the research that I've done and of thinking about this challenge that you as behavioral health agencies have and we as consumers have. And then finally, as always, there'll be time for questions, comments. I'm with the Echo Group. The Echo Group has been privately owned since 1981. We are an electronic health record, and I have a unique job at Echo Group, but the Echo Group as a whole is an electronic health record, and we implement and support and provide partnerships with our customers in that work. We also have a revenue cycle optimization that helps folks who need a little bit more support in the billing side and gives us the ability to ensure that we sort of meet our mission statement, which is to make our partners clinically effective and financially strong. Julie told you a little bit about me. Here's way more than you need to know. But I've been in healthcare for a long time, and while in healthcare, I've really worked across the continuum of care, from representing hospitals and doctors to getting started in managed care when managed care was really in its infancy. And over the course of that time, I've had the occasion, and really, I'll say pleasure, to watch the trends, to see how things change, and to sometimes take the time to read the tea leaves to get an idea of where healthcare might be going. So why is there integrated care? You know, integrated care started maybe to save money, maybe to address needs. And one of the things that happened as healthcare moved through the world and moved through time and space, we got better at understanding data. We learned more about the populations that we served, and we could make decisions based on those populations. So if you look at these numbers, about 18.6% of adults across the United States have a mental illness. And 20% of those folks, or 1 in 5, have a severe or serious mental illness. 68% of that number have one or more chronic physical conditions. Percentages are nice, but let me break this into numbers. Approximately 46 million adults have a mental illness. Over 9 million have a severe or serious mental illness. And over 31 million have one or more chronic physical conditions. Important to understand, this doesn't say which came first, the chronic physical condition or the mental illness. It allows us to really take into what we know is that when a person has a chronic physical condition, the likelihood of them suffering some kind of diagnosable mental illness grows exponentially, as you might well imagine. The next number is a little bit, off-putting maybe to me. Primary care physicians prescribe 67% of the psychotropic medications that are prescribed in the United States and 80% of the antidepressants. What this says very clearly is that PCPs are, whether they're trained as psychiatrists or trained as PCPs, are managing not just the physical health needs of their clients, but the behavioral health needs as well. And while that might be the choice of the PCPs, the focus of the PCPs, that next number, I think, tells a better story of why that might be. If only 1 in 4 people referred to specialty mental health providers make their first appointment, the PCPs are going to be on the hook for managing those meds because they're not seeing somebody who may be more trained to deal with those issues. So from these numbers and from the realization that those numbers provided, integrated care was developed. To talk about integrated care, we're going to look at the definitions of them because as we go forward into this discussion, the definitions become really important. So the first 2 levels of integrated care really based on coordinated care. Communication. I'm going to pick up the phone and I'm going to talk to that therapist and tell them that this client needs to see them. Or the therapist is going to pick up the phone and call the doctor to see how the diabetes is being treated, how it's going, what the numbers are. It's minimal and it's at a distance. And with those 2 key elements, really doesn't give you a concept that that's integration. It's really more some sort of managed dialogue, let's say. So then comes the second level, or level 3 and 4 of coordinated care, where the key element is physical proximity. I may have basic collaboration on site, Maybe I brought a behavioral health therapist into my PCT office, and I can talk to her or him whenever I need to based on the needs of a client. Or I may be a little bit better integrated where I have some system integration ability. Maybe I have IM, and I can just IM the behavioral health provider that I've seen this person. Maybe there's a bit of a shared record. In either instance, what you really have is the beginnings, the very beginnings of what you might consider true integration. I'm going to make staff available so I can better serve the needs of the client, or maybe there's another reason, and we'll talk about that. The third area, and really the final idea of integrated care, the direction that really programs the government, CMS, would like to see us move, to see this industry as well as the American Medical Association move, is a full integration, a change in the practice methodology. This is close collaboration, approaching an integrated practice, or a full collaboration in a true integrated practice. In that integrated practice, I'm going to share my record. It's going to be a single care record. I'm going to have a single, perhaps, treatment plan when dealing with mental illness and chronic illness. I'm going to have case studies and case reviews that involve the full continuum of care being provided a single client. I am going to be fully integrated based on what the needs of each of the clients in our practice needs. This is looking at it from a structural standpoint, almost like a building. I got a telephone, I have a building that may have an office, now I have one building. Another way to look at integrated care is to look at the continuum of physical and behavioral health care from the actions of the participants, of the staff. In the first level, we see screening and navigators, meaning people that can kind of help you see where you need to go, when you need to go there. Not a lot of integration, not a lot of talking amongst themselves, but the idea, the first real break in the system where we're not two separate, indistinct systems, we are moving towards one system where I'm going to look to you to provide additional care needed by my client. Then we move into care and case managers. I think this is a critical element, depending on the focus and who they work for. And that's something I'll talk about when I talk about next a vision for a future. But the care managers and the case managers are helping the clients and the staff navigate the process, identifying the services that need to be provided and determining where and when those services can be provided. This moves us into maybe co-location, where we're going to have everybody in the same location, making the case manager's job a little bit easier because there's maybe one single front desk staff that can manage the calendars of the different providers. Also, you may have heard of health homes. This was a construct of the Affordable Care Act and is continuing on. And this is where you offer true coordinated care to individuals who have multiple chronic illnesses and mental health instances, or maybe substance use disorders. It's not a physical home in any way. It's a clinical approach that includes the client and the providers and the family members, where appropriate, to kind of give the sense of a home, of a single place to go, a single way method to get those services that you're going to need. Again, it's very much like that full system level integration. So what I want to do next is look at the final concept of integration that I want you to remember as we go through the rest of our conversation. Integration means somebody moves somewhere, or everybody moves to a new place, but somebody has to move. Integration means there's a marriage of two very distinct types of practice. You've got behavioral health and primary care. And very simply, behavioral health providers might move into primary care settings, or primary care providers may move into behavioral health settings. Each meets the definition of behavioral health, and each provides a little different focus of what those services that are going to be provided really are. And I want you to remember this particular picture as we move through the balance of the discussion, because it's very much the end result of what kind of the points I want to make, and sort of what I'm thinking is it makes a difference which form of integration you use. It makes a real difference, not just to the longevity of behavioral health providers, but to the quality of care that the clients are receiving throughout the course of their treatment. So, I said we had integrated care because of numbers. And when we look at what has been identified as the values of behavioral health, of integrated care, you're going to see something that if you've been to anything I've talked about or others should look familiar. The triple aim, something that came out of the Affordable Care Act based on some academic research done prior to that. And it's looking at three disparate things that the synergy of bringing them together is supposed to bring down the cost of healthcare. Let's look, better care for individuals. That might give a hint as to the person-centered that's coming up. But here is the better care of individuals. Each individual has their own process by which they receive care, their own needs, their own challenges, and require a particular plan for the treatment of those. Better health for the population. To one degree or another, if every individual has better health, then as you look at the population as a whole, there's better health. But this also means more of sort of the feedback loop. As I learn how to better treat the individuals and I feed it into the population, I'm going to improve the population health by that activity. And the final piece is lower cost through improvement. If you read the articles, if you read the academic analysis and the governmental analysis of integration, they do talk about care and they talk about the client. But the number one fact that comes up over and over again is if we can figure out how to bill for it, we can reduce the cost of care. Because we are ensuring that care is provided by the person most capable to provide that care. That is certainly the goal, and it is certainly what the numbers why the review of integrated care goes on a continual basis to see how that is working out. Since integrated care is an ongoing process, I want to look a little bit about what people are saying about it. So what the staff have to say is that it's building a culture of collaboration within the organization. Makes sense, because for there to be integrated care, there has to be collaborative care. Staff are getting to learn new skills. Most doctors, most behavioral health providers, most nurses didn't learn collaborative care or integrated care when they were getting their professional degrees. It's newer than that. Maybe it's being taught in some of the schools now, but it hasn't always been. So you're giving these staff members the opportunity to expand their concept of practice, to learn new skills, to engage in orientation and training. And finally, it utilizes something that you may have heard about before, a warm handoff, meaning that I'm going to provide, rather than call somebody or refer somebody with a piece of paper, I'm going to walk that person over to the room where they need to be and give them the ability to have that conversation and talk about the things that they want to talk about. So it's going to be a warm handoff. If we've looked at how the staff view integrated care, what about the participants? Well, the participants say, in many studies, the showing is that patients prefer it. They have a better sense of the care that they're providing. That referral source that was 1 in 4 prior to integrated care is now up to 40 to 60%. The personal relationships that got lost when neighborhood health care got lost are now being developed again. People are able to develop personal relationships with their healthcare providers. There's more accurate understanding of the client's case. I, as a behavioral health provider, am going to get a better idea of the chronic healthcare challenges, and the people providing long-term care for the chronic challenges are going to get a better sense of what the behavior, the mental health challenges are for those clients. There's also an opportunity for informal consultation. Maybe it goes without saying, but in my office, in your office, business sometimes gets done in the hallways. Information gets shared in the hallways. This allows for informal consultation. Maybe it's not client-specific, but you're seeing numbers that you've never seen before because of the healthcare needs of the person. And you can go say, what does it mean if an A1C is at this number versus this number? Should I be worried? Is that something I want to talk to my client about coming to see you and getting better help? And finally, there's a single clinical record, which is going to reduce errors. As I was thinking about this, I thought about back when I was a kid and people played operator. You know, the game where you whisper one thing to one person who whispers it to another and another. And by the time it gets all around the table, it's a wholly different message. Well, if you think about the level of communication being brief or almost non-existent, as in the first level of integration, that's really operator. I'm going to pass a message to somebody at the front desk that I hope the doctor's going to get because I really need the doctor to know it. Maybe it wasn't perfectly transcribed, and by the time the doctor gets it, it's not the message I intended. Well, if you have one single clinical record, those errors go away. In addition, and I mentioned this briefly, you have the opportunity to have a single treatment plan if it's appropriate, where all parties participate to understand what is that integrated, what are the services that are going to be provided across the continuum to best serve the client. Well, as you probably well know, and there would be no academic articles ever if this weren't the case, wherever there are benefits, there are going to also be identified barriers. The insufficient number of staff. And while this is a barrier to integrated care, in my state, in your state, in probably every state, this is a barrier to care across the country. There aren't enough trained staff of a particular type, be it clinicians, psychiatrists, pediatricians. There are not enough staff anywhere, and this is just bringing it a new a different light on that problem, because to provide true integrated care, I have to have an integrated team where all different persons are available. There are disagreements about provider roles. And this is easy to understand. In my youth, I worked in a law office. You learn one way to do something, and somebody else comes in and says, no, I think we should do it that way. You have your back hair goes up and says, no, this is the way we've done it, this is the way we're going to continue to do it. We've already talked about the fact that integrated care is a new muscle. It's not a muscle every doctor, every behavioral health provider had. When you come in and tell me to use that new muscle, I'm going to say, those old muscles work much better, and I have much better muscle memory there. Restrictions on sharing patient information. For behavioral health providers, you're very well aware of this, especially as it relates to substance abuse treatment. You can't share that data unless a specific release is placed. Now, I will say in the revisions of 42 CFR Part 2, there was an attempt to deal with integrated care, and that will help. But if clients really do feel that it's a better method of care, there's also a greater opportunity to get those releases signed so that data can get shared. This little piece about policies are hindering reimbursement. While the government may have identified integrated care as a really good idea, they didn't quite follow with how the dollars track in integrated care. So there is some problem. Many states have problems getting the case management and other services, or when there are two services in one day, a physical health and a behavioral health, getting both of those services reimbursed. If the purpose of integrated care, one of the main purposes, is to reduce the cost of care, a cynic could say, well, they reduced it by not providing the service codes necessary to bill for it. A realist could say, that's something that just needs to get addressed, and it should be addressed at the state level and at the federal level so that those services, if they have value, really will be reimbursed. And there's a workflow and logistical obstacles. I look at this as a learning curve and an acceptance curve. 10 years ago, 5 years ago, when people were given electronic health records for the first time, they didn't want to use them. They thought Word, Excel, and a piece of paper and pencil was much better. I know there's some that still believe that, but there's also people who understand now that if I can put my data in a computer and share it across, that's a good thing. But that acceptance was slow in coming. This too has those same challenges. I've managed John's care perfectly for 10 years. Why do I need to work with his doctor? That's all taken care of. I've got John's back on this. I can take care of it. That's going to fight the move towards integrated care. And that is what happens at times until medical schools and clinical programs and other programs catch up to the new ways of providing care. So we've spent a good portion of time on integrated care. And at each way along the continuum of the discussion, we've talked about person-centered. That the person because the person is receiving the care. I love that there's a building where everybody goes to. I love that there's one record. But I worry about that client getting the care that they need in a way that they understand it. Let's look at person-centered care now. What are the ingredients of person-centered care? Holism, or treating the person as a whole person. Naming. And this one is a real big issue, as you well know. Does my provider know my name? Moreover, does my provider know the name I go by? My legal name is Susan. Nobody calls me that. Everybody calls me Suki. When I see my provider, she calls me Suki. When I see somebody else in her office, they call me Susan. Heed. Does my provider listen to me? Even seriously mentally ill persons. persons with substance abuse, persons with chronic care have a voice? Does my provider listen to that voice and treat me with respect as it relates to my voice? Compassion. Does my provider care for me? When I am suffering because I'm sick or because I'm depressed, does my provider actually care about me? Agency and empowerment. Am I involved in my care, or am I just the recipient of care? I want to be involved. I want to be able to make decisions. I want to be the center of it, not the doctor's office, not my doctor. And finally, continuity of care. Do I see the same provider every time I come into my office or the office? Probably not. But if not, does every provider in that place have information to help them focus on me, understand me, know who I am? The first point I think is important, and why I've researched this topic and spent some time thinking about it. Generally integrated care, even as I described it, looks at how patients fit within integrated services. In a true person-centered plan, I want to look at how services fit into my patient's world, into my world as the patient. That's what I want to know. That's what I need to know. So what are some of the things that I might ask to really get to person-centered care? Is the care a means to an end or an end to itself? Are you going to kick me out after I get my service, my 4 visits, and that's it, I'm done? Or do I stay involved? And do you stay involved? Are patients subjects or objects? In the early definitions of integrated care, I dare you to tell me that patients were the subjects, because integrated care was at a process to deal with clients. They were objects of the results of the integrated care, of the conversations. In true person-centered care, they would be the subjects of care. Everything that gets done, everything that goes around, is based on that, them being the subjects. Are patients individuals or aggregates? Interesting. If you think about this against the triple aim says that healthcare requires patients to be both individuals and aggregates. Probably not a secret that I'm going to fight against that a tad bit and say that I don't know. Patient data can be aggregated, but patients shouldn't be aggregated, because as a patient I am unique by my illness, by my diagnosis, by my level of education, by what keeps me up at night. That's unique to me. You can aggregate my numbers all you want, but you cannot aggregate my care and still let me feel like my care is focused on me, is person-centered. Finally, how do we know the patient's wants and needs? Well, gosh, if you've aggregated care, you don't need to know my wants and needs, because you just take somebody that's sort of like me and know what their wants and needs are, and you got it made. Except then I'm going to walk out and I'm not going to come back. And I'm going to be one of the 1 in 4 that doesn't follow through and go get care. I'm going to be one of the clients who tries everything they know how to do to opt out of that health home, even though it's the right place for me to be because of my chronic illness. I'm going to be unhappy. And one of the challenges you have with unhappy clients is that most people don't know how to talk to doctors or doctors' offices or providers. Most people don't know how to express that frustration or are afraid to express that frustration. So if you create a system that increases the level of frustration and the client doesn't know how to respond to the frustration, you're not providing care to those clients. You are merely doing what you think you're supposed to do to provide service to an object that happens to be a client. Anybody who's heard me talk before knows that soapboxes are my friends, and I do tend to get on them. But I want to talk now about where I think another way of looking at this that I think would be so wonderful. Let's redefine integrated care to make the client the center of integration. Not by accident, not by proxy, but by reality. The client who can do it will learn the options that they have and make the decisions that they want that are best for them. And if you make the client the center of integration, the dollars ought to flow from the clients to the providers based on client-determined need. I don't want my doctor telling me what I need to do and getting paid for that. I want to tell my doctor what I need based on information that I can understand. And then they get paid for it. And not until. I don't want to go see a therapist because my doctor told me to. I want to understand why it is I need to go see a therapist. And if I understand that, I will go. And the money should follow me. Now, there are people who are listening to this who say, oh no, there are schizophrenic clients, there are seriously mentally ill clients who cannot manage that, who can't manage making those decisions. That's true. And for them, more needs to be done. The client needs to be supported by a behavioral health care case manager who works for the client at the place of service. And I'm going to tell you, I have two instances in my own life where I am confident that the case manager did not work for the client, but worked for the hospital or the rehab facility. Because the things they said to the families wouldn't be said by anybody who understood the fear in the families and the needs of the family. And that's got to stop. The case manager has to, one, be trained how to listen and how to manage information coming to them. Something that's generally taught. It's taught more, I would suggest, in clinical programs than in many medical schools, but I could be wrong. And they have to be reimbursed for those services because those services have a real value. Because those services are the critical services to get to the value that really is then extended into the provider network. I am proposing that you make true person-centered care the cornerstone of integrated care. I'm not saying integrated care doesn't have a purpose. It does. When all my providers can talk to each other, that's perfect. But if I'm not at the center of that conversation, if I'm not directing what I want, what I need, or somebody who speaks for me isn't doing that, then I don't get what I need. That case manager, when appropriate, will work beyond the client, but with the family. Or if the client is elderly and needs the family to speak for them, or is suffering from a mental illness that requires family assistance, they can speak to the family. And that family will own. That person-centered would be a family-centered care. And those people would manage the money still. They would say, this is the care I want my family member to receive. These are the needs. And you, behavioral health case manager, care manager, because you work for me, I know you'll make sure that that's what happens. Another element here is the problem of data sharing will disappear over time. Because if I'm the center of my care and I'm suffering from substance abuse and I trust you with that information because I trust you, I will share that information. And that challenge of incomplete record in integrated care will go away. Not only will I trust that that data can get shared, but I will know how it's shared because I will be working with my behavioral health care case manager to follow that data, to understand that data, to get my services, to ensure that my story is told once and shared amongst a group of people. The advantage to me, I never share my story again if I don't want to. Why should I as the client, as the patient, have to tell people twice what my problem is? I get to say it once, and the world gets to share it the way they should so they know it as they provide care to me. This is a paradigm shift. There is no doubt about it. It is a paradigm shift to the providers, to the funders, and to the concept of integrated care. Because nobody's done this before. This isn't the way it works. Well, maybe let me be fair there. Someone amongst you may say, yes, it does. I know the place. Great. But that place hasn't managed its way into the literature, into the academic reviews, into the theses, the PhD theses that get written. We do understand that not all clients will be the manager of their own care, but they will have a trusted relationship that will assist them in the management. And should, through that trusted relationship, they become able to manage their own care, that trusted case manager will see it, know it, and act upon it, and pass the management back to the client. Somebody who is dealing with substance abuse, who successfully makes it into recovery, one of the benefits would be their care management in the same structure moves back to them. They are empowered. They get what they have to do. Care managers don't exist. They're going to need to be trained because right now every care manager is reimbursed by the agency that they work for or the contract agency they work for. I want them to be paid by the client. I truly want them to, because if they are paid by the client, then their boss, to one degree or another, their audience is the client. They are the ombudsman, for another term, for that client, and will help that client work their way through the integrated care system that exists for that client. Paradigm shifts are hard. People don't want to do them. It's an ongoing challenge in every office that changes the way they do things, in every home that changes the way they do things. My home included. Shifting paradigm can really upset. It's going to cause a undertow in the flow of data, in the flow of activity. But were it to occur, the benefit, I think, would be real and tangible. So what does this require? Nothing. Just, we're going to wake up tomorrow, it's going to be this way. Or we're going to have to redesign the definition of integration pathway to be client-focused. Not as the second thought or the third thought or the fourth thought, but as the first thought. Give you an idea. In reading some of the literature, they had elements to be considered when looking at the proper method of integration. There were 20 points. What was the 20th point? The needs of the client. What am I suggesting? the needs of the client become the first point. With this solution, integration has to be PCPs working with behavioral health agencies, because it is the behavioral health agencies that are truly going to understand and be the conduit of information. They're trained to do it. They're in the place to do it. They've identified a desire to do it in many ways. So they need to be the center, and everything will flow from them. And in the center of the center will be the case manager and the client. We have to teach clients to find their active voice. We've talked about the need to train staff and the need to train others, but we also need to train clients to find their active voice. Because without that active voice, this won't work. But clients can be taught to find that active voice. And we have to find a way to do that, to get to every client, to be able to talk not just when they're really pissed off, but when they want to be constructive, when they want care, when they want to know, what am I supposed to do to deal with this? And it will be the care managers, these newly trained care managers, whose job it is to train the voice in the client, to give the client a safe place to practice that voice and to use that voice. And finally, because deep down inside, I too am a numbers person, and how do you measure the success of this? It's going to be to do short-term and long-term client and family outcomes. What was the level of satisfaction? What was the level of improvement at the client level? Within the family dynamic or constructs, how was that? Did it make them feel more comfortable with the treatment of their spouse, of their child, of their parent? That's what I want to know. That's what we need to check. That's what we need to monitor. And not here, but I will say, because I just have this, we need to think about the triple aim, about what it really says about our intent to listen to a client. And maybe we need to come up at some point with a new version of the triple aim that focuses with the client in the center. In the middle of that triangle is the client. And then around the client are those other elements that are important to the quality of healthcare across the country. So as I step quietly down from my soapbox, at this point I'm going to hand it back to Julie and say I'm very welcome. I welcome you questions and comments.
Great. Suki, thank you so much for your insight. We would like to remind everyone that you can use that Q&A area below the slides on your screen to submit a question at any time. And as a reminder, if you're interested in downloading the slides, they are available in the Resources tab to the right of the presentation window. Also a reminder that CE credit is not available for this program. So let's dig in. Suki, you had mentioned holism early on, and can you talk about how spirituality might fit into that concept of holism?
You know, I think spirituality and mindfulness are very important in that holism, because it speaks to how I understand the world around me and how willing I am to participate in the world around me. If you respect me and I respect me, and I understand my relationship to the world, then I may be more willing to engage in the world. My family preaches mindfulness to me all the time, so that's why I had to throw that in, just out of deference to them. But I think that spirituality and mindfulness are very similar. I have to be understanding of my place in the world to be supportive of my place in the world.
Great. And in thinking about integration in a big picture sense, are there channels that can collect patient data in between scheduled healthcare visits, and what might that look like, and can any of that be integrated?
Absolutely. I've seen programs in various states that do this with, and there's a lot of studying going on this that I find really interesting. But in the use of mobile apps, it is a way for that behavioral health provider, for the doctor's office to keep in touch. There are ways to know that the person's taking meds, although maybe that's too intrusive in the world I'm talking about, but checking in with them. How are you doing? Did you test your blood sugar at lunch before you ate it? Those are the kinds of things that I, as the care manager who's working for the client, really want to make sure they did, and talking to them in a way that's comfortable for them, electronically as an example, or in the old days you'd pick up a phone and call one landline to another. Not done so much anymore. But you can do it. I don't care if you keep it HIPAA, if you're not worried about HIPAA, use whatever. If I'm talking to a teenager, I may very well use Snapchat, because gosh knows they're looking at that. If I'm talking to another adult, I could text them. And if I need to, and I want to be sharing HIPAA-compliant HIPAA data, then I'm going to give every client that comes in a HIPAA-compliant app to put on their phone that allows us to talk when they're not in the office, to maintain those lines of communication in the ways that make people most comfortable.
Great. And I have a question about ACOs. Do accountable care organizations still exist, and do they integrate behavioral health care services and data?
Yes, they do, and they're supposed to. They do exist in some places. They are still waivers that were recently approved that include affordable care organizations, or ACOs, and they do collect data. They have to, in order to prove their worth, in essence, or for value-based payments. Many of them are on some kind of capitation or value-based payment structure. They do exist. They're less referred to in relationship to integration, because integration focuses on the medical health home, but there's no reason why that is, other than it's just sort of where the literature's gone, I guess. I talked to SAMHSA and others to figure out, a lot of the literature is driven by the things that are produced from the government, and they flow down either from this government or from one of the other, Canada, England, also produce a lot of data and literature about integrated care. Australia.
Great, and let's fit in one last one. What new skills will clinicians need for integrated care in the future?
They will have to learn, they will have to learn how to work with doctors, how to read physical charts as well as behavioral health charts. They will have to learn how to provide data that isn't too much but isn't too little, to identify the areas. They know a vast amount about their clients. They need to understand the salient points that are important for whatever the chronic illness is or the health issue is. And that's a challenge, because you don't learn a lot about physical health maladies when you become a clinician. So that's they're going to get training in that, and training in managing teamwork, because I'm not sure how many people in this day and age really understand how to do that, and that's going to be a training for everybody.
Great. Those are all the questions that we have for today, but I do want to thank Suki Norris once again for an excellent presentation. I would also like to thank our sponsor, Echo Group, for making today's program possible. And finally, thank you to everyone in our audience for participating today. We do hope you'll join us again in the future for another IABHC webinar. This concludes today's presentation.